Very good morning to everyone. Thanks to IPDI for arranging this program and inviting me to deliver the lectures on the emerging therapy for the dyslipidemia management. I will be in brief and will be confined to the practical approaches of the emerging therapy. The present key points in the present management of the dyslipidemia is the lowering of the LDL by the statins prevents the SCVD with mortality benefit. Statins are the first line therapy in both primary and secondary prevention. With maximal dose of the statins, there remains still some residual risk of the SCVD. Significant residual cardiovascular risk has been reported among statin-treated individuals, even with otherwise low LDL-C level. LDL goal is not achieved with the sole use of the statins in a number of cases, and there are patients who cannot tolerate the dose of the statins recommended to achieve the goal, and a few patients are intolerant to the statins. So emerging therapy in practice are in the two ways. The emerging targets, the LDL needs to be further lower, the lower is better, and there needs to be acute reduction of the LDL, the faster, lower the LDL faster, and the triglyceride-rich lipoproteins and the remnant cholesterol, and the LPA is the new marker of the atherosclerotic cardiovascular disease risk. And the emerging therapeutic agents are the bempedoic acid for the reduction of the LDL, the PCSK9 inhibitors, inclisiran, and eicosapentaenoic acids. There are a lot of other things in pipe, but I will be in brief with the practical approaches. And this is a slide which shows the drugs with CV outcome trial, the statins, ezetimibe, PCSK9 inhibitors for the LDL reduction, and the new therapies are bempedoic acid, inclisiran, and there is other things. Even the vaccine is also tried. And the TGRL, that is the triglyceride-rich lipoproteins, the fibrase and eicosapent ethyl are the agents which are approved for the lowering the TGRL. And the newer drug, particularly the pemafibrates, is being tried in a large trial. In the regarding the LPA, there is no specific therapy, but the pelacarsen and olpasiran are the agents which may reduce the LPA, but whether these are the beneficial effects on the atherosclerotic cardiovascular disease is yet to be understood. These are the slides that shows that the PCSK9 inhibitors, they reduce the LDL by the 60% within 1 to 4 weeks. This is the earliest time. This is the earliest time that the PCSK9 acts before the other agents acts. ApoB, I'm not going in details. The efforts to lower the ApoB containing lipoproteins in the plasma are the centerpiece of studies. Whether we say about the LDL, VLDL, or the TG rich lipoprotein, this ApoB particle is the more important. Number of the ApoB particle in a particular lipoprotein is more important for the assessment of the risk factors for the atherosclerotic cardiovascular disease. I'm not going to, a persistent elevation of the ApoB can be considered as a risk enhancing factor, and ApoB may be the primary driver. They are considering that the primary driver in the JAMA Cardiology 2022, they are the primary driver of the atherosclerosis, and that lowering the overall concentration of all ApoB containing lipoprotein should be the focus of the therapeutic studies, not the LDL only. PCSK pathway is the novel pathway that in the revolutionary development in the domain of the lipid lowering strategies has been the discovery of the proprotein converted sublitocin caxin type 9. This has been described as long as the 60s, but the clinical utility of the PCSK9 pathway for the control of the risk of the atherosclerotic cardiovascular disease has gained momentum just a decade back. This pathway is being interfered either by the human monoclonal antibodies that degrade the PCSK9, and nucleic acid-based therapeutics to decrease the production of the PCSK9. What we need to decrease or need to have the low level of the PCSK9 to have the more LDL receptor so that the circulating LDL can be cleared off. So these are the pathway. PCSK9, PCSK9 cause the lysosomal degradation of the LDL-C and the LDL receptors, and the LDLs is metabolized to the LDL receptor on the hepatocyte. So less LDL receptor means less clearance of the LDL. There is a more LDL is due to the PCSK9. So if we give the inhibitors, there is a less degradation of the LDL receptors, more LDL receptor, more clearance of the LDL, and there is a decreased plasma LDL. And another is the small interfering RNA mechanism, that the nucleotides, they less production, they act on the production of level of the PCSK9. So there is a less production of the PCSK9, so there is a less level of the, there is more receptors, there is less degradation of the receptor. So these are the two trials. These are the two trials. One is the Odyssey outcome trial by the Alirocumab trial. Another is the Evolocumab by the Fourier trial. And they either by 2 weekly doses or by the monthly doses. And the reduction is the up to 60%. And the indication is the currently approved indication is the clinical activity of the Alirocumab, and particularly the familial hypercholesterolemia. These PCSK9 inhibitors are approved. And these are some trials, I'm not going in details, by which it has been found that the Evolocumab and both the Alirocumab are far better in the LDL reduction than the placebo over the top of the statin therapy. These agents are used over the top of the statin therapy. These are the recommendations from the ACC guideline and also the ESC guideline. In the class 1 indication, when there is a LDL level is more, even after giving the maximal tolerated statin and the ezetimibe, it is the class 1 indication in both the guidelines. And the small interfering RNA inclisiran, it has been approved in the European Medical Agency, is the first small interfering RNA evaluated for dyslipidemia, and the LDL-C lowering is about 50%. And what is the benefit of the inclisiran is that the less frequent doses, can be given by the 6 monthly dose. Sorry. I think this is very complicated, but you see the inclisiran acts on this way. The nuclear formation of the PCSK9 is inhibited by the inclisiran, and the PCSK9 inhibitors act on this side. So both are acting on the same pathway, but in the different routes. Bempedoic acid is now available in Bangladesh market. It is similar to the statins, but it blocks the cholesterol synthesis upstream the statins. And another feature is that it is a pro-drug which is activated only in the liver, so its action is liver specific, unlike the statins. So there is less muscle symptoms is explained by this mechanism. And these are the clear harmony trial, where the addition of the bempedoic acid over the maximally tolerated statins have been found to be useful. Sorry. And the triglyceride and remnants, which are before 5 years or 10 years back, it was not considered very much, but the serum triglyceride-rich lipoprotein and their remnants are constantly associated with the ASCVT beyond the LDL level. This is the more focus nowadays. So remnant particles are the triglyceride-rich lipoprotein that have been partially lipolyzed by the action of the lipoprotein lipase. I'm not going, that's just this diagram we can see. Sorry. These are the triglyceride-rich lipoproteins, which is lipolyzed by the lipoprotein lipase into the remnant-rich lipoproteins, and these can enter the endothelial cells and they cause the atheroma, formation of the atheroma. And the lowering of the TG, this is the REDUCE-IT trial, which is published in 2019. It says that the risk of the ischemic events, including the cardiovascular death, was significantly lower versus the placebo, with the 4 gram of eicosapentaenoic acid per day, for 2 gram twice daily eicosapentaenoic acid per day, lowers the TG as well as the cardiovascular event. But the strength trial, which is published in 2020, they use the eicosapentaenoic and docosahexaenoic acid in the 4 gram, but no significant difference. So this is a negative result. And the evaporate trial, they found that there is a significant reduction of the atheroma burden by the IVAS or MDCT by the significant regression of the plaque. And another trial is going on now, prominent trial, which the pemafibrate is used to reduce the TG, and whether this reduction of the TG is associated with the reduction of the cardiac events will be published later on. LPA, this is a very discussed topic nowadays, is a modified form of the LDL, independent, genetically determined risk factor for the ASCVD. Till now, LPA has been considered as the surrogate marker of the high risk of the atherosclerotic cardiovascular disease. But recently, there is some trials to see whether the lowering of the LPA will be beneficial in the lowering of the risk of the atherosclerotic cardiovascular. It is no more only a marker of the atherosclerotic cardiovascular high risk of the cardiovascular disease. I'm not going to detail. The recent data with the PCSK9 inhibitors suggest a possible role for LP lowering in reducing the CV risk. And this is a diagram. This is the European Heart Journal. It says that the statins lowered the LDL, but there is no effect on the LPA. When we use the LDL and the PCSK9, it reduces the LDL as well as the LPA. And there are some drugs, ASO, antisense oligonucleotides, which lowers the LPA without reducing the LDL. But whether this affects the cardiovascular disease risk, we have yet to wait to further investigation. And this is brainstorming pictures, how the different lipid modifying drugs act. You see, these are the ezetimibe absorption obstruction. The bile acid sequestrant also acts on the gut wall, and the lomitepide on the gut wall. And there is a inclisiran in the production of the PCSK9. There is a PCSK9 inhibitors in the wall, in the LDL receptors. Destruction is inhibited by the PCSK9 inhibitors. Statins on the production of the cholesterol, bempedoic acid also on the production of the cholesterol, and there is other drugs which are in pipeline in these lipid modifying therapeutic agents. Now, my dear colleagues, the chairpersons, the take-home message is that till now, statins remain the backbone of the LDL lowering therapy till now, as the concept of lower is better is accepted. Adjunctive therapy is needed. As you know, the current recommendation is frequently to use the ezetimibe along with the statins. And the PCSK9 inhibitor has emerged as additional therapy to achieve the LDL goal, not only better, but also faster. As you see, the PCSK9 can lower the LDL within 1 week. So we can use the PCSK9 inhibitors in the acute coronary syndrome to have the lowered level of the LDL as early as possible. Bempedoic acid may be considered when statins are not tolerated, particularly due to the muscle symptoms, or sometimes we can add to the statins in the lower dose of the statins along with the bempedoic acid, 180 milligram per day. It is available in Bangladesh nowadays. Inclisiran twice a year dose may be proved to be more compliant if cost barrier is overcome, because there is a highly costly drug. And sooner, the Bangladesh will get this drug available in the market. Triglyceride and remnant cholesterol is another target to reduce the risk of ASCVD. EPA, eicosapentaenoic acid, has been, sometimes they say the IPA, the eicosa is written as the I, started with the I, has been considered as a good agent to reduce the TG and consequently the risk of ASCVD. There is a mistake in the spelling. LP has been considered as a marker of the risk of ASCVD, but recent studies indicate that the lowering of the LPA by the PCSK9 is associated with the lowering risk of the ASCVD. And there are a number of the nucleic acid-based therapies, antisense oligonucleotides, ASO and SIRNA, that is the small interfering RNA, under trials for the management of the dyslipidemia. And maybe in the next lecture we can talk more about this, the nucleic acid-based therapies. I think that's the end of the. Thank you very much for the passion here.